Okay. Hello, everyone. Hello, Prof. Wun-Hao Cheng. How are you?
Yeah, hello. Yeah,
It's been a long time.
yeah, it's been a long time.
Hello, thank you.
Mm.
Maybe we can start now. Are you?
Uh, can we start from now?
Of course, I think that's already 9
Oh
a.m.
yeah, okay. Okay, so Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Morning, everyone. Distinguished speaker, honor cast, and all participants joining us today. Welcome to our webinar titled The Mechanism of Infection-Induced Asthma. We are
Mm.
truly delighted to have you with us for this important scientific discussion. My name is Ayuning Tias, and I will be your master of ceremony for today's event. And before we begin, kindly take note of a few reminders. First, the session will be recorded and shared with registered participants. Second, please keep your microphone muted throughout the presentation. The third, you may submit your question via the Q&A box at any time. Fourth, attendance and evaluation links will be provided at the end of the event. And the last one, will be issued to participants who complete the attendance form. All right, ladies and gentlemen, moving on to the next part of our program. And now it is time to introduce our moderator for today's seminar. Our moderator is Dr. Gigi Farah Sylvia Yuliani, MSc Ph.D., who currently serves as lecturer at Master Program in Tropical Medicine, Faculty of Medicine, Health and Nursing at Universitas Gadjah Mada. We are truly honored to have her with us today. And without any further ado, I would like to invite our moderator, to lead and guide to the next session. Dr. Farah, the time is yours.
Thank you very much, Ayu, for the time and introduce us. And Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome to our online guest lecture hosted by Master in Tropical Medicine Program, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. And my name is Farah Sylvia Yuliani, and I have the pleasure of serving as the moderator for today's session entitled The Mechanism of Infection-Induced Asthma. Thank you to all lecturers, colleagues, and students who are joining us today from various institutions. As we know that asthma remains a major global health problem, and in many tropical countries, we frequently see asthma that is triggered or worsened by respiratory infections. Understanding how infections interact with the immune system and the airways is essential for improving prevention and treatment strategies. And today we will learn more about how infections can trigger and worsen asthma, the role of airway epithelial cells, different inflammatory patterns, and how these mechanisms can inform better prevention and treatment strategies. And we hope this lecture will enrich our understanding and inspire further clinical and research collaboration. And I hope in this guest lecture, we hope to deepen our understanding, in pathophysiology and mechanism of infection-induced asthma, and to link this knowledge, to clinical practice, as we mentioned before. And at this time, it is a great honor for us to have Dr. Wun-Hao Cheng, Ph.D., as our main speaker today. Dr. Wun-Hao Cheng is a assistant professor at the School of Respiratory Therapy, College of Medicine, Taipei Medical University, Taiwan. He has a strong background and experience in respiratory therapy and respiratory disease, including infection-related airways disorder and asthma. And we are grateful that Dr. Cheng is willing to share his expertise with us today, despite his busy schedule. Thank you very much, Dr. Cheng, for your time. I know that you are very busy. Thank you very much. And before we start, let me briefly explain the flow of today's session. First, Dr. Chen will deliver his lecture, and after that, we will have a question and answer session or Q&A session. And for participants, please keep your microphone muted during lecture. And if you have questions, you can write them in Zoom chat box at any time or use the raise hand feature during the discussion session. And when you are invited to speak, please briefly introduce your name and affiliation before asking your question. And this event includes an e-certificate for all registered participants following completion of attendance and the feedback form that will be shared at the end of these sessions. Without further ado, we would now like to invite Dr. Wun-Hao Cheng, Ph.D., to deliver his lecture on the mechanisms of infection-induced asthma. Dr. Cheng, the screen is yours. Thank you very
Yeah,
much.
thank you, Farah. I try to share my screen first.
Okay,
Okay,
you can try. Okay,
so you
yes,
can see my slide. It move.
yes, good.
Okay,
It's
okay.
clear.
Thank you. I 有了开了 opening and Farah 的开了 introduce. And my name is Wun-Hao Cheng from the School of Respiratory Therapy, Taipei Medical University, Taiwan. And today I am very happy to share my the study and the mechanism of infection-induced asthma. It's a very, I think that is a very important public health issue, and we need to focus on how to the specific to treat different type of asthma. And infection-induced asthma maybe the other specific major reason induce one of the type of asthma. Okay, so let me start the background. So the first we need to know how to manage the asthma in general standard therapy. In usually the asthma we use inhaler use a corticosteroid to control their patient symptom. Some patient may be combined with bronchodilator treat the asthma symptom. Around 24% of asthma patient use a high dose corticosteroid and bronchodilator. They can oral corticosteroid. They can control their symptom. Around 17% to 3.7%, they even use steroid and bronchodilator. It cannot poor controlling their symptom, and maybe also usually happen acute exacerbation. This group of asthma we call to the severe asthma. It's very poor controlling to treat an asthma patient. And you maybe will ask questions. Only 3.7% of severe asthma had a bigger effect in clinical practice. It's interesting. In previous investigation, we find that the 3.7% of severe asthma you have all the asthma treatment cost 50%. So that's a big problem in clinical and have a business and marketing in here to find how to treat this severe asthma patient. Because it have asthma treatment the 50% cost is very huge and big. The problem is here. Okay, so what's the risk factor can induce the severe asthma? As usually we all know that allergen, a cytokine inflammatory mediator can induce the asthma inflammation. Moreover, the bacteria and gene it also can induce the pulmonary allergy inflammation in here. We will can see when our respiratory system to stimulate this risk factor, then we induce the alarming cytokine is very important inflammatory mediator in the asthma process, include the IL-25, 33, TSLP, and alarming cytokine will be released from epithelial cell. And they will induce a lot of inflammation the process and the immune cell cytokine storm, and will also cause the epithelial barrier dysfunction with the junction protein decrease, include the interherin, HO1, and the codeine family. That will cause our airway environment to be weak and very easy to be infection and finally cause airway fibrosis. So you can see when after airway inflammation and then the fibrocyte activation, myofibrous differentiation finally cause airway fibrosis. So in all asthma process and the environment, the airway inflammation and airway fibrosis is very important to therapy target to heal. And recently in the study, the airway epithelium and airway epithelial cell is more play important role in a severe asthma. The process asthmatic inflammatory. You can see the in healthy patient, the epithelial cell will be have a good protective barrier with junction protein. It can defend the internal stimulation and to protect the fibroblast and the immune cell and can be activate. But in the asthma patient, the junction protein will be decreased and the barrier, epithelial barrier will be destroyed. That's very easy to release the immune cell and the fibroblast to activate by the external stimulation. For example, the allergen, fungus, bacteria, virus, even air pollution and smoke. That will induce very so that will be very induce allowed immune cell activation, recruitment to our airway epithelium. It also induce myofibrous proliferation, smooth muscle increase, and angiogenesis inflammatory increase, and progress the asthma, the patient, the symptom, and the acute exacerbation. So as we know, the airway epithelial cell is a very important driver in a severe asthma and pathogenesis. So to process to treat this severe asthma, we must to know what's the different inflammatory mechanism in different type of severe asthma. In usually, the if you usually is a allergy or hostile mind induce the asthma type usually is a T2 high asthma. It indicates type 2 inflammation induce asthma. So the process is like this: allergen will increase activate the Th2 cell and B cell. That would release allowed the IgE that induce muscle cell deactivation. And also, the Th2 cell will release a lot of T2 cytokine IL-4, 5, and 13. Now we recur a lot of eosinophil and to here induce will maybe you know that eosinophil inflammation. That's it indicate that. And it also will cause the smooth muscle, hyperplasia and contraction, and to induce asthma, the symptom acute exacerbation. So let's say the T2 high asthma is maybe usually induced by allergen and hostile mind like this. And the other one, we could not T2 high, not T2 inflammation. We usually go to a T2 low asthma. Okay, the usually is induced by the cigarette smoke, inflammatory toxin, virus, and bacteria microbiome. That will induce allowed Th17 and Th1 cell, the immune cell activation. That will release the interleukin A17 and TNF alpha and recruit a lot of neutrophil to the here. So in a titular asthma, we call to neutrophilia inflammation. It's different titular asthma like eosinophil. So in immune cell, the environment in T2 high and T2 low is totally different. And by different inducer, it cause the same the symptom and asthma the acute exacerbation. But the reason is one totally different and here. And right now, the clinical practice, if T2 high asthma have allowed a specific monoclonal antibody to treat. One is tetopilimumab, dopilumab, benalizumab, mepolizumab, and monalizumab is a focus target the T2 cytokine 4513 or TSLP. However, still now, the T2 asthma is not specific to the drug and treatment or a manual antibody to treat this T2 severe asthma. So this is still is a major problem if we the smoker virus bacteria induce exacerbate the titular severe asthma, how to treat and how to control this patient is still need to further investigation. So as we know, like the pollution, smoke, even to obesity and infection, it usually it induce the T2 asthma because they will activate non-Th2 cell inflammation. It usually induce a Th17 or Th1. Level Th17 will secrete interleukin 17 and interleukin C. Some smoke will induce interleukin A. That will recruit allow the neutrophil to heal and form the neutrophil inflammation and exacerbate the asthma and the asthma symptom. So the pollution, smoke, and the infection it promote airway neutrophil inflammation, increase the severe asthma exacerbation. They play a very important role in the T2 low severe asthma process. So also, we will focus on bacterial infection. Usually, bacterial infection will also use release a lot of LPS to infect our epithelial cell and induce a lot of immune cell. A detail is like the bacteria or LPS will induce a lot of interferon gamma, TNF alpha, and 6 will be released from epithelial cell. They also will know that this cytokine would activate the macrophage and Th17 cell and to release a lot of IL-17. It also will increase TNF alpha, IL-1, IL-1 beta, and IL-A, and recruit a lot of neutrophil to our airway epithelium, and it is form neutrophilial inflammation. Also, the bacteria, the LPS, would inhibit the Th2 cell, the activation. The Th2 cell in the activation is mean to inhibit eosinophil the recruitment to the airway epithelium here and it reduce the eosinophil inflammation. So in a clinical outcome, we can see a neutrophil recruitment and induce neutrophil dominant inflammation and induce airway exacerbation. So totally different the mechanism and induce severe asthma exacerbation. In LPS-induced asthma, usually is T2 low and the neutrophil the inflammation. And now we still know the specific the treatment strategy to reduce the LPS and induce neutrophilic the severe asthma exacerbation. So that's why we need to research to the list topic. So in previous study is already show like how to define the T2 low severe asthma or LPS induced severe asthma animal model. We usually use host dust mine, the HDN combine the LPS to induce neutrophilic asthma. Okay, so we can see like the HDN and combined LPS is aspects, the total IgE and HDL IgE increase combined only the orange, the HDL stimulation. That means the LPS will amplify the severe asthma, the inflammation, the process, the outcome, there will be the increase. You also can see the HE staining and the past staining also can show that HDN combine the LPS with the amplify the airway, the remodeling, and the inflammation, the inflammatory cell, the recruitment here combine the HDN and the PBS the mouse. But also we can see the path is indicate the mucus the indicator like the purple the color. We also can see the HDN and the PS can amplify compare HDN and PBS the mucus the production in a airway from the HDN and the PS in the mice. But also in the Western blood it show like the junction protein marker according claudin family. The HDN combined LPS can decrease this junction protein expression. So this result indicate that LPS can amplify the HDN-induced airway inflammation and also can destroy the epithelial barrier, the function, and induce asthma exacerbation. But also, the virus is also the important can aspect the asthma the symptom. The previous study also show that the rhinovirus or the ISV virus they can induce the asthma symptom. To they have to check when we add rhinovirus infection, then will increase the acute asthma the severity score to increase. Also, the mice IgE, host mice IgE, and total IgE after the rhinovirus invasion will increase this IgE the level. That means the rhinovirus also amplify the IgE and the asthma, the symptom, and the inflammation. Moreover, we previous study also show that if you do the 3D culture that's from the asthma patient use epithelial cell and to infection the rhinovirus to the human epithelial cell after 24 hours, and we would find that the junction protein gene expression and apoptosis related gene expression after the rhinovirus infection, this the junction protein the expression will be decreased. In indicate the junction the barrier will dysfunction. But also the apoptosis related gene the after rhinovirus to treatment in an asthma patient, this gene expression will also to increase. That may also indicate rhinovirus infection with dysregulate epithelial barrier function and apoptosis pathway in recent asthma. So that's an easier summary which will show that the pathogen, no matter it's virus and the bacterial infection, will induce the asthma, the expansion. It's very play an important role the asthma the pathogenesis, disease severity, and the exacerbation risk. And the mechanism is totally different in the allergic induced the asthma. And the virus infection also play an important role. Is associate the early onset patient symptom, maybe airway contraction and induce the wheezing and the asthma susceptibility in childrenhood. So, based on this reason, we already know the T2 low asthma or the LPS-induced asthma is the very good treatment to this patient. So we want to find the good target to do this research. So in a recent research study show that The IL-6 transsignaling is play very important role in the neutrophil asthma, and have it show like when our MSC cell exposed in infection, usually will find a toll signaling. The toll signaling activate the MSC cell will release allowed interleukin 6. The interleukin 6 will shedding the neutrophil, the interleukin 6 receptor, the phone, the soluble form interleukin 6 receptor. That will combine with interleukin 6 it forms a complex and induce we call to the interleukin 6 transsignaling. It's different only interleukin 6 classical signaling is a combined soluble form interleukin 6 receptor and to amplify the tissue epithelial cell, the barrier, the dysfunction, and the increase allowed immune cell inflammatory cytokine the release increase and the immune cell abnormal activation. And finally, expansion, the submucosal inflammation, and the airway remodeling. Okay, so we can see this gene expression and see the healthy interleukin 6 transsignaling low and the intertranssignaling high the stimulation. And we see this junction protein, the claudin family, the gene expression will be decreased under the interleukin 6 transsignaling high. That means they indicate the interleukin transsignaling is play an important role in on the barrier function and junction protein expression. Also, we can use the tier. It's less resistant. It's an indicate the barrier function. When epithelial barrier function is normal the function, we will have higher resistance to defend the external the stimulation, the bacteria, the fungus. But when the junction protein the dysfunction and its barrier function is lower, the resistance will be decreased. It's mainly our epithelial cell is sensitive, easily to sense to bacterial infection or allergy the stimulation. And we can also see that the combined the interleukin 6 transsignaling, this one, the circle one, it will significantly decrease the resistance, it means the barrier function. It's also the indicate the interleukin 6 transsignaling will dysregulate the barrier function compare only interleukin 6 and soluble form interleukin 6 receptor. So we want to we know the interleukin 6 signaling is very important role and on the barrier function. So also we use this picture the figure show like different interleukin 6 signal. In the interleukin 6 classical signal is the yellow one is interleukin 6. The usually about in the blue one, the interleukin 6 receptor, that will activate the classical signaling. They usually use anti-inflammatory rule and can induce epithelial barrier polarization and have a balanced T cell, the median immunity. But the interleukin 6 transsignaling is totally different. The interleukin 6 will combine the soluble form interleukin 6 receptor. They usually will activate the GP130 is a layer receptor. They will activate the YAP, PI3K, ERK, and the juxtapose the kinase signaling and induce pro-inflammatory process, induce leukocyte immune cell requirement and tumorigenesis and fever. So when you know that interleukin 6 transsignaling usually play a very important role in induce inflammation. It also will have a find that interleukin 6 transsignaling is maybe associated the epithelial barrier function. So we just want to know target the interleukin 6 transsignaling is maybe the good the target to treat the neutrophil and NOPS induced asthma. So we have an aim to want to investigate IL-6 transientally, maybe the activate the airway and the epithelial cell, induce the ENT, and the HDA combined and PS induce the severe asthma, specific neutrophilic asthma, and T2 low asthma. So we have a very simple preliminary result to show that we usually send the HD and combine LPS to sensitize and challenge around 1 month. And we indeed show that an HDN combined LPS and induce a severe and significant airway inflammation and airway remodeling here. We also would have a mission the mice as lung function to see the FEV 0.1 is similar the patient FEV1 and the compliance and the resistant and after the mesacholine stimulation. The mesacholine stimulation is it can induce the bronchial response to mimic the patient asthma the acute aspiration. And we highlight after the mesacholine stimulation and or a different dose the mesacholine the stimulation, the HDN and combined the LPS, the lung function will significantly decline, and the resistance will be significantly increase. It means that the HDN combined LPS can activate the airway, the bronchospasm, and the airway the symptom, and the mimic the asthma, the mice. Also in the epithelial cell, we have treated LPS the different dose. And we can also see like the ecdysherin is a junction protein that indicate the epithelial barrier function. With a high dose NOPS will decrease junction protein loss and induce airway epithelial barrier dysfunction. That's also indicate the HD and NOPS can induce barrier dysfunction and or aspect the airway the lung function decline. But also, we use the interleukin-6 transientally to observe the ENT marker, include the incate the fibronectin, the JO1. The incate the JO1 is a junction protein marker. And we see that when our combined interleukin-6 and the soluble form interleukin-6 receptor to mimic the interleukin-6 transientally, and we see that the junction protein with a significant decrease, and the mesenchymal marker protein, fibrosis marker protein, fibronectin, with significant increase combine only the interleukin-6 receptor and the interleukin-6 stimulation. So that means the interleukin-6 transientally can induce significant the junction protein dysfunction and fibrotic protein expression. Also, we have checked interleukin-6 transientally the different time interval and to observe the toe signally. We previously showed that the toe signal is very important to sense the pathogen, LPS, host dust mine, all important receptor receptor length and amplifying the airway information. It will also show that interleukin-6 transientally will significantly increase the TOEFL the expression. So maybe can induce the sensitization to um, uh, expose when our airway epithelial cell exposed to the LPS, the RH, the stimulation. So also in the animal model, we also try to target the interleukin-6 transientally. So we use previous animal model HD combined LPS to mimic the infection-induced severe asthma model. And we try to IP the anti-IL-6 every per the 3 day, and to try to block the interleukin-6 signally and transientally. And we can see that in the our animal model and the IgC expression to observe the total expression. You can see the HDN LPS combined anti-IL-6 therapy that can decrease the airway inflammation and remodeling. It also decrease the total expression in this mice group. But also, the junctional protein is also will be recovered. Is combine the anti-IL-6 therapy. And in our immune cell the profile, we can see a similar result. The HDN and the PS can induce eosinophil lymphocyte and the neutrophil the expression increase, significant increase. And combine the anti-IL-6 therapy, the immune profile will be a decrease. So this data totally indicate the anti-IL-6 reduce the HD combined LPS and reduce the TOFO expression and the ENT the barrier dysfunction. So we have this preliminary result have the summaries. In the leukocyte trend signaling is met exacerbate N1 ampicillin cell and HDN and combined LPS induce the severe asthma the mice. So maybe it is a very good target to treat the infection and induce the severe asthma in the patient. But also, is the same in the previous slide. The airway ampicillin cell not just only the barrier function, it also include a lot of subtype. The different subtype ampicillin cell is playing a different role and contribute the severe asthma and inflammation. So the ampicillin cells include the basal cell, Gerber cell, and the ciliary cell. The basal cell is a progenitor cell. It's responsible for differentiation into the different epithelial cell, such as the ciliary cell, Gerber cell, or cup cell. So it's like this epithelial cell model. Okay, the Gerber cell and ciliary cell is differentiation from the basal cell. And the Gerber cell and club cell is responsible for the mucus cell production. Okay, and the C cell is responsible for remove this mucus and define external stimulation, fungus and bacteria virus. Okay, and when the asthma patient ampicillin airway ampicillin not only barrier dysfunction and the ampicillin cell with abnormal differentiation. So the basal cell maybe will cannot be differentiation to the other epithelial cell, or is abnormal differentiation only to the mucosal cell, like the Gerber cell. So the Gerber cell maybe will hyperplasia or or a proliferation of the Gerber cell and induce mucus hypersecretion. So that's why the asthma patient or airway disease patient, their airway around the mucus and very easy to get the cold. That's because in an airway disease or the asthma, the patient, the airway epithelial barrier function totally different, and the composition is also different. It's not just only a basal cell, globular cell, ciliary cell. And maybe only change allowed globular cell the differentiation and product allow the mucus to the secretion, okay, and exacerbate the patient symptom. So that's why maybe we should not only to investigate the junction protein function, we maybe need to more to know that the different ampicillin cell, how to interaction, and maybe the list of different ampicillin cell, how to interaction the immune cell or fibroblast or endothelial cell or the smooth muscle cell. So to solve this problem, we need to the high resolution the investigation research the tool. We use the single cell the sequencing to clarify this question. So we want to investigate critical molecular mechanism or the cell interaction is under the different endotype. The T2 high, T2 low, normal, different endotype, the asthma has different mechanism, different cell interaction, and induce different the environment. So we use a single cell to analyze and solve this problem. So we try to perform this single cell. We to try to correlate bronchial tissue from the T2 high, T2 low asthma patient in our hospital. Okay, so after digest the tissue, we use a 10x genomic single cell to analysis. So we can see this result. It's a normal patient, T2 low patient, and the T2 high the asthma patient. Okay, and this all the cell from the patient, and is we like this cell we according gene expression and have distribution. Okay, so after our annotation, we can show that this the cell the cluster is a major is a celiac cell. Okay, so it's a normal celiac cell, T2 low celiac cell, and the T2 high celiac cell. So the same and similar is normal global cell here, T2 low global cell, the T2 high global cell. It also some basal cell here. Okay, the normal basal cell, T2 low basal cell, and T2 high basal cell, and some mucus cell and some immune cell. And we use a single cell, we can identify every subtype amphincillin cell and the immune cell and in here. I try to know what's the different the type, the T2 low, T2 high, the asthma type, and the different mechanism and interaction. So we use we try to analyze this. We use cell-cell communication to observe the different asthma type, the different cell type interaction. So we can see the circle one is a different cell. Okay, it means a different cell. And some is immune cell, and some is amphincillin cell. The line is mean the cell and cell connection and cell communication. Okay, so we can see this is a normal cell and cell. Okay, different cell type, the communication and the interaction. And in the T2 asthma, compare normal, we can see the line, the density is very different, right? It's higher than a normal. That's what it means. In a T2 high asthma, the environment, the cell-cell interaction, it will be increased. Communication will be increased. And compare the T2 low, the communication and not to density not increase, but that only focus some the cell population, the major. You can see the basal cell, right? The thickness is different. Compare normal and compare T2 high, right? So only a basal cell, CD8 cell, and microphage. This is different compared normal and T2 high. So let me make the indicator in cell lineation, the T2 low asthma patient. The basal cell and the CD8 cell maybe play an important role and contribute the different communication in the T2 low neutrophil, the severe asthma patient. Okay, so we can use the signal pattern to see, to observe what's the connection, what's the signal, the connection in a different across this cell type. We can see like this is a normal patient, a healthy patient, And this is a T2 low asthma patient and the T2 high asthma patient. Okay, we can choose highlights. The T2 low and the T2 high asthma, the signal, the pattern is different than normal. Okay, this can make sense because T2 low and T2 high asthma in the inflammatory and different in the how do I say, right now they is in the inflammatory process, right? So it makes sense. It can different in a healthier patient. Okay, and we can see like this is every signaling. Okay, every signaling, and the green one is indicate which this signaling to happen, which the cell type. Okay, so you can see macrophage, ciliary cell, basal cell, globular cell, and monocyte. And the different cell type will happen which one the signaling in here. Okay, so we can show that the T2 low, the asthma patient have a specific signaling in here compared healthy and the T2 high. Right? So it's a major indicator. This signal is played a very important role in the T2 low the environment and the T2 low the severe asthma, the inflammation. Okay, so we just focus in simple. Because the previous slide we show like the T2 low the asthma, the ciliary cell, basal cell is different signaling interaction compared normal and T2 high, right? So if we try to investigate the CD8 specific deuterosomal means undifferentiated CD8 cell. The undifferentiated CD8 cell, which signaling is more specific increase. As we can see, the twinkle signaling is higher expression in here. So maybe the twinkle signaling is a very important rule in the deuterosomal CD8 cell. So we can more clear to see lights. This is a chart plot. And if we want to see the twinkle signal in the network, and we can see that the twinkle signal network usually is regulated by the macrophage, ILC, and the fibroblast to induce the basal cell and the ciliary cell to activation. Okay, so let's use a heat map can see like who is the sender and who is the receiver in a trigger signal the passive network, and this result and it also indicate that the macrophage, right, is a very important sender to give the signal to the basal cell, and due to some of the ciliated cell. So we can know that twinkle signal white can infect the deuterosomal ciliary cell or a basal cell. What from the signal the source what from maybe is from the macrophage can activate that. So it's a different previous study like use the single cell analysis we can more higher resolution the what happened the signal to in the show the signal in the cell and cell interaction and the communication. Okay. So we also can see the twinkle signal. The twinkle is the signal the ligand. Okay, so we can see that different cell type and the different patient source. The healthy T2 low, T2 high, the ciliary cell, ILC cell, NKT cell, master cell. This ligand higher express which cell type and from which patient. And we can see that the twink is high expression in ILC T2 low. It's also see the macrophage T2 low, and or fibroblast, the T2 low is maybe also maybe the candidate, the source from this cell and this patient. And also we can see which receptor receiver the protein expression. The FN14 or TNFR SF12A is a twin signally very important receptor. We also can see like in the autosomal, the T2 low, the asthma, the receptor protein expression is higher. It's also higher in the mast cell and the basal cell. So compare this analysis, single cell analysis, we can see like in the encountering signaling heat map, it show like the specific the signaling pathway. Twink, interfere, PLAU, and try the least signal pathway in T2 low, and neutrophil, the severe asthma. Okay, so we will show the network analysis. It highlights how to tune the signaling, the type of communication and different cell type. We find that the twinkle signaling may be okay due to some cell cell the major receiver. Who is the sender? Maybe microvirus, maybe mast cell. Okay, so this given provide us the very good the rationale to investigate maybe this signaling and this cell the population contribute and the titular the severe asthma the disease the progression. Okay, so maybe we can because right now we have a continue to this research. So in our future work we will identify the autosomal the CD cell, the abnormal differentiation and the titular asthma and induce different T2 high and healthy the asthma healthy environment and the information are different. And we will try to functional validation with real to the signals happen in a severe autosomal asthma and in titular asthma. Okay, so that's my sharing. Okay, so this is my lab, and recently we have very have a good opportunity to collaborate with Dr. Farah and IU to do this research. If you have interesting our study, this is my information. It's very welcome to contact me, and which we can have try to discuss more experiment study or design and in T2 or infection or asthma the study. Thank you.
Thank you very much, Dr. Cheng, for your very excellent presentations. This is very insightful for us about this asthma. Yeah, so there is a difference mechanism between allergic induced asthma and infection-induced asthma. And you also showed a single cell sequence, single cell data, and then you also showed your future works. And it's very interesting for us to see your works also. And of course, if the students here, maybe our colleagues or students interested to study about this, maybe you can contact Dr. Cheng or maybe me, yeah, to connect, yeah, to connect. Like previously, IU also works in Dr. Cheng lab, yeah, and then it shows that very good data. And I call Dr. Cheng Dr. Roy, Prof. Roy.
Yeah.
I call him Roy. I call him Roy because previously he helps me a lot in my PhD study. Thank you very much. And also, yeah, if you have some questions, yeah, to Dr. Roy or Dr. Chen, you can raise your hand. Yeah, maybe I haven't see any chat box here. It's depends on you. Terserah. Mau tanya apa? Sorry, I will I will in bahasa. Ibu bapak atau teman-teman mahasiswa yang mungkin ada pertanyaan atau mungkin ada interest atau ingin penelitian, beliau sangat terbuka untuk bekerja sama ya. Very welcome, Dr. Cheng, very welcome to collaboration. Bahkan kemarin beliau itu menawarkan siapa yang akan meneruskan Ayu ya, siapa yang ada teman-teman di sini yang mungkin akan mengambil atau studi di Taiwan itu sangat welcome. Bahkan beliau juga akan menyediakan reagen, kemudian labnya ya. Mungkin di kita hanya bukan hanya ya, mungkin kita akan mencoba mencari hibah atau grant yang mungkin bisa membawa teman-teman semua ke sana ya barang 1 bulan atau 2 bulan untuk ambil data atau untuk eksperimen di sana itu beliau sangat welcome. Kemarin menanyakan Farah siapa ya yang selanjutnya akan ke sini gitu. Yes, I asked, I told them that maybe if they or the students want to do experiments or do research in your lab, you are very welcome.
Yeah, I'm very welcome. Yeah,
Yeah.
I would look forward come to here, and
Mhm.
maybe next year or next year, I will want to go to your country.
Of
Yeah,
course.
yeah,
Very,
have a
we will,
real face-to-face talk and discuss this. Yeah,
yeah, we are very uh, welcome and waiting for you and maybe your family to come to visit here. And
yeah,
yeah, yeah, yeah. And this very,
I will if you invite me next
of
year.
course, I
Yeah,
I will try to find a funding so we can invite you here because it's very interesting when you also show your single cell data. I think it's not
mm-hmm.
only for asthma, but other
Yeah,
diseases also can
yeah,
be implemented. So I would like to maybe next time you teach us, maybe you have like a course, maybe small course, you teach us about this single cell data. For example,
mm-hmm.
for database, right? Database,
Yeah.
right?
Data. Asthma is we development.
Mhm.
But right now have a public data around about maybe cancer and
Mhm,
COPD,
mhm.
and we collaborate with the TB, right?
Yeah, yeah,
We
yeah.
can use the open data to analysis.
Yeah.
I can teach you how
Mhm.
to use the public data and
Ah,
annotation to analysis the single cell results.
yeah,
And
yeah,
we will teach you how to learn because just the beginning very
yes.
difficult because we don't know how to use we use the R Studio the software and
Mhm.
just teach you how to use R Studio software how to write a code, right? And if
Yeah,
you
yeah.
want to add more data,
Mhm.
you can learn by yourself. Just
Mhm.
beginning, I
Yeah,
can
yeah,
teach
yes.
you. Yeah, yeah. Because after then,
Mhm.
design, just use a different code and produce a different result. Yes.
Yes, yes, we can.
Mm.
Yeah, yes. This is important when you say that this
Yeah,
is the
maybe we can
beginning.
very easy
Uh-huh.
small workshop and to
Small
teach how
workshop. Yeah,
to
yeah.
use public data and to perform this
Mhm.
single cell RNA sequencing results. Yes.
Yes, thank you very much. Maybe next time we can because in this study program or in this faculty there are many students not only studied asthma but maybe cancer and then other diseases ya. Mungkin teman-teman
Yeah,
yang di
cancer, air pollution,
air
COPD,
pollution
and
ya, air pollution.
yeah, a lot of
Yeah, air
public
pollution.
data. You can use
Public
their
data.
the result to do your research because single
Mm-hmm.
cell the result too many. We
Yeah.
can analyze all the result by ourselves. So you
Mm-hmm.
can use the public result to try to analysis and make your rationale, make your hypothesis to do your experiment.
Yes, yes,
Yes. Mm.
yes. So yeah, next time we can yeah. This is
Okay.
jadi teman-teman bisa suatu saat nanti bisa belajar. Mungkin kami berharap bisa mendatangkan beliau untuk mengajari. Jadi single cell itu kita mau apa namanya ingin melihat dari public data. Terus kemudian kita proses, kita analisis. Misalnya mana protein mana yang paling banyak terekspresi, misalnya di kanker atau di TB atau di manapun penyakit manapun infeksi ataupun yang non infection. Nah, kemudian setelah itu bisa dilanjutkan, oh misalnya penyakit protein ini yang banyak terekspresi, ini mekanismenya seperti apa ya. Next time kita akan coba. Sorry, there is one questions from
Okay.
Pak Dodi, Mr. Dodi. Can IL-6-TS be considered a key mediator in the pathogenesis of chronic respiratory disease through the
Mm.
induction of EMT and the enhancement of innate immunity? Wow, so many questions. I hope you can one by
Many
one
questions.
answer. Thank you very much for the participants who questions this. Maybe first questions you can see in the chat box. Can you see in the chat box, Dr. Roy?
Which
Oh,
one?
yes. Okay,
Sorry.
okay. Sorry. Thank you.
Oh, so which I back to Zoom. How? Where? Sorry. Where is the question? Sorry.
Can
Here,
in the
right?
chat box. Yes.
Okay. Sorry.
No problem. It's
So
okay.
here, right?
Yes.
I don't think it can be considered by key mediator pathogenesis. Oh, sorry,
Chronic
induction
respiratory.
ENT. Yeah, we want to prove this. Right? In actually, this is my study topic. We hypothesis this, and in our animal model and cell in vitro cell, indeed show that the interleukin is play an important profile role in the ENT process and enhance in the innate immune response because we can see in the mice the immune the cell the profile will be increased. So yes, I think it's yes. And
Second.
Bara blah 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 and UGM failing hello and information battery after yes different yeah gram negative and gram positive bacteria is different. But
Mm.
but we should just maybe easily focus the uh, LPS induced severe asthma because the mechanism still clear. So we
Mm.
should one by one to answer the problem. Yeah. So yes, in health and social infection, yeah, it may be secondary asthma episode. Yes. Different underlying mechanism. Yeah, we believe it's a different underlying mechanism. Sometimes it will be a complex because so that's why we want to use single cell data because right now we just focus LPS amplify the
Mm.
severe asthma, the information process, right? But you haven't mentioned about maybe different bacterial sepsis or virus, maybe the mechanism totally different. We just see the result. The virus and the bacteria or infection, LPS can exacerbate the asthma, the symptom, but maybe the mechanism totally different. So I show that we took previously the severe asthma, the therapy. We just not only T2 high, T2 low. We maybe combine the cobility, right? Maybe one is uh, bacteria infection and severe asthma. They have a specific treatment protocol. The virus induced severe asthma progression. They have a specific treatment protocol. Like right now, COPD, we have a combined the cobility. The COPD, the guideline have shown that in different cobility, obesity induced COPD, eosinophil COPD, or air pollution induced COPD have a different therapy guideline. So we show one by one to reveal that. So I think it's the mechanism indeed different, but we should try to modify the investigation to do that. Thank you.
Okay. Recommend management?
Okay.
And would be the recommend management in such cases? This last question. And what would be the recommend management? Hello? Can you hear me?
Me?
Yeah, Dr.
Oh,
Roy.
sorry. Sorry. Again.
Sorry, this is the last. And what
Yeah.
would be the recommend management in such cases? The management.
Oh, recommend management. Right now, antibiotic, the microbiome is maybe benefit in some titular asthma, the antibiotic, but they have such a some side effect because they use a lot of antibiotic to treat this severe asthma patient. Maybe will induce resistant the bacteria, right? So maybe will that's maybe not good to the outcome. Maybe it can shortly control the asthma the symptom, but we will produce a lot of resistant the bacteria, drug bacteria. So right now we still to find right now we have not an answer. But in the experiment, this patient use antibiotic, the therapy can
Right.
shortly to improve their symptom. But maybe you should accept this sign effect. The drug resistant the bacteria will be produced. Yes. So that's why we need to do a research. And the other the potential the therapies they have mentioned about that the alarming. The alarming is
Alarming.
yeah, alarming is very good indicator. Recently, the clinical the research TSLAP was approved by to treat T2I asthma. But the news, the clinical study more indicate that in part maybe have a benefit in the titular asthma. So right now in our country in a hospital, we try to use anti-TSLP, the monoantibody tetrapirumet, to
Oh.
observe the titular asthma the outcome, right?
Wow, that's new insight for us also, and we hope
Yes.
that because this research is more and more advanced, I hope it can be a good choice for the treatment for asthma patients, particularly in severe asthma.
Yes.
Yeah.
Yeah.
Maybe any other questions more? Thank you, Pak Dodi, and thank you, Pak Rosa, for the questions. Yes, I hope, yeah, next time it's very interesting, yeah, to invite you again to
Yeah. Thank you.
to teach us about yeah, your study
Not teaching, just sharing and discuss. Yeah.
sharing. I know, yeah. I saw your citations, publications is very high for your.
No.
Recently, our collaborations, not in in your paper, first author, about amphiregulin. Yeah, amphiregulin. It's you. Many people cited your paper.
Yeah. Really?
Yeah. I saw that because it noticed in my email. And no more questions? I have questions, but maybe it's very limited time. Maybe and it's already others have raised the questions and you answered very complete. But maybe because I would like to inform again to my colleague or other students here that maybe this is if you have other research focus, yeah, not in asthma, maybe in COPD or in cancer, yeah, like IU previously connected about
TB infection.
TB infection, yeah, TB infection and as inflammation, yeah, in lung
Yeah, inflammation.
inflammation, Yeah, so there are many various focus, yeah, in disease that we can learn from this. Yeah, so I hope you can share your knowledge next time. Yeah, maybe for focusing on single cell to public or open data. Yeah, so we can analyze this for each of the students. Yeah,
Yes.
or
Yeah.
maybe the researcher or students who will study it or do experiments in your lab. Yeah, I hope
Uh,
we can
yeah.
have more collaboration ya. Jadi teman-teman
Yes.
atau yang ingin memiliki kontak dengan beliau atau ingin melakukan studi di Taiwan ya, sangat-sangat terbuka. Mungkin saya perlu menginformasikan lagi karena ini kesempatan yang sangat menarik ya. Beliau akan memprovide ya baik reagen apapun ya, bench dan semuanya kita kita mungkin lebih ke tiket atau living cost di sana. Dan living cost di sana nampaknya juga tidak terlalu high ya. Kita bisa mungkin akan mencari hibah atau mencari funding mungkin untuk akomodasi di sana, tetapi untuk riset beliau akan memprovide itu. Okay, if there is no more questions, I think that's all, Dr. Roy, Dr. Cheng. Yeah, we are
Yeah.
now coming on the end of our sessions. On behalf of Master in Tropical Medicine Program, Universitas Gadjah
Yeah.
Mada, UGM, I would like to express our sincere gratitude to Dr. Wun-Hao Cheng or Dr. Roy for the excellent and informative lecture, and to all participants for your active engagement. We hope this session has enriched your understanding of infection-induced asthma and inspired further clinical and research collaborations in respiratory and tropical medicine, or maybe
Yes.
biomedical field, yeah. And please remember to fill in the attendance and feedback form that has been shared in the chat, and each certificate will be sent to participants through the contact detail provided at registration. And thank you again, Dr. Chen. And then I
Yeah.
will send back to MC, Mbak Ayu. Thank you very
Yeah.
much.
Okay, thank you so much for Dr. Wun-Hao Cheng, PhD, for the comprehensive and insightful presentation, and Dr. Farah for leading us in this webinar so everything went smoothly. So before we close today's event, we would like to invite all participants to join our group for the session. If it's possible, please turn on your cameras and we'll take a few moments to let everyone get ready. Okay? Okay, all right, here we go. On the count of three. One, two, three. Once more. One, two, three. All right, perfect. Thank you so much for everyone.
Thank
And
you.
as we reach at the end of our webinar, we would like to extend our deepest appreciation to our distinguished speaker, the organizing committee, and all participants who joined us today. So we hope today's discussion has enriched your knowledge and inspired further interest in respiratory and infection-related researchers or other researchers or the research. Yeah. So thank you once again for being part of this event. Stay safe, stay healthy, and we look forward to seeing you in our future webinars. Thank you so much,
Thank
everyone.
you,
Thank
everyone.
you. Thank you, Farah. Thank
Thank
you,
you,
Ayu.
Roy. Thank you,
Thank you,
Ayu. Thank
everyone.
you.
Thank you.
Terima
Thank
kasih
you.
semuanya
Yeah.
untuk
Yeah.
pasnya. Matur nuwun sangat. Semoga
Bye
bisa.
bye.
Bye
Bye.
bye.